Module 9, Diabetes. Type 1 diabetes mellitus accounts for 5 to 10% of all individuals with diabetes mellitus. Type 1 diabetes has a virtual lack of insulin production and a severely compromised counter-regulatory protective mechanism. The individual with type 1 diabetes must receive insulin replacement therapy to survive. Type 2 diabetes accounts for 90 to 95% of those with diabetes. It was formerly known as adult onset or non-insulin diabetes mellitus. Individuals with type 2 diabetes can produce insulin. Their blood glucose protective counter-regulatory mechanisms are preserved for years. These individuals are treated with diet and often with oral hypoglycemic medications. Individuals with type 2 diabetes who also require insulin for control of their blood glucose are becoming more prevalent as the population ages. While the detection and management of both hyperglycemia and hypoglycemia are important aspects of the overall medical management of a person with diabetes, the detection and management of hypoglycemia is more relevant to safety concerns in the certification of the commercial motor vehicle driver. Some of the factors related to commercial driving that affect blood glucose include fatigue, lack of sleep, poor diet, missed meals, emotional conditions, stress, and concomitant illness. These same factors may hasten the need for the driver with diabetes who does not use insulin to start insulin therapy. Poorly controlled diabetes can result in serious life-threatening health consequences. However, with good management of the disease process, a driver with diabetes can safely operate a commercial motor vehicle. The complications of diabetes can lead to medical conditions severe enough to be disqualifying, such as neuropathy, retinopathy, and nephropathy. Accelerated atherosclerosis is a major complication of diabetes involving the coronary, cerebral, and peripheral vessels. Individuals with diabetes are at an increased risk for coronary heart disease and have a higher incidence of painless myocardial infarction than individuals who do not have diabetes. Preventing hypoglycemia is the most critical and challenging safety issue for any driver with diabetes. Hypoglycemia can occur in individuals with diabetes who both use and do not use insulin. Mild hypoglycemia causes rapid heart rate, sweating, weakness, and hunger. Severe hypoglycemia can cause symptoms that interfere with safe driving. Per regulations, you must review and discuss with the driver any yes or not sure responses to the health history questions regarding diabetes on the medical examination report form. For the driver with diabetes, ask, does the driver routinely monitor blood glucose levels, use over-the-counter medications or supplements, have a history of fainting, dizziness, or loss of consciousness, have a history of hypoglycemic reactions that resulted in seizure, loss of consciousness, need of assistance from another person, a period of impaired cognitive function that occurred without warning. The minimum physical examination requires assessment for target organ damage associated with dysfunction of the senses and includes evaluation for diabetic retinopathy, macular degeneration, peripheral neuropathy. The primary care provider and the medical examiner have different concerns. The clinician treating the commercial motor vehicle driver is primarily concerned with minimizing target organ damage associated with elevated blood glucose. The medical examiner assesses the driver's risk for a severe hypoglycemic episode or the effect of organ dysfunction on the driver's ability to safely operate a commercial motor vehicle. For the purposes of a DOT exam, the FMCSA distinguishes between a driver with insulin-treated diabetes mellitus and a driver with non-insulin-treated diabetes. Previously, a driver with insulin-treated diabetes could not be certified to drive a commercial motor vehicle unless the driver obtained a federal diabetes exemption from the Federal Motor Carrier Safety Administration. In 2018, the FMCSA passed the diabetes regulation, which allowed, for the first time, drivers with insulin-treated diabetes to be certified by a medical examiner to drive a commercial motor vehicle. This regulation eliminated the need for the federal diabetes exemption program. However, the regulation did create a specific protocol that the examiner must follow in order to certify a driver with insulin-treated diabetes. So, to clarify, in order to certify a driver with insulin-treated diabetes, you must follow the regulatory steps. You have no discretion to deviate from the certification protocol. However, for drivers with non-insulin treated diabetes, certification is based on guidance, and you do have discretion, as we are about to discuss. We will now review the process for certification of the driver with insulin-treated diabetes. Again, this is a regulatory requirement. You can expect several questions regarding certification of a driver with insulin-treated diabetes on the NRCME certification exam. The process for the certification of the driver with insulin-treated diabetes starts with the treating clinician, defined as the healthcare professional who manages and prescribes insulin for the treatment of the driver's diabetes. The treating clinician is not limited to a specific discipline and does not need to be an endocrinologist. The treating clinician must complete the ITDM assessment form, MCSA 5870, attesting that the driver maintains a stable insulin regimen and proper control of diabetes. Upon completion of this form, the treating clinician must sign and date the form and provide his or her full name, office address, and telephone number on the form. The driver then presents for the DOT exam with Form 5870 in hand. The medical examiner must receive the form and begin the medical examination no later than 45 days after the date on the signed form. However, the medical certification determination does not need to be completed within 45 days. It is a regulatory requirement that a driver with insulin-treated diabetes must meet all requirements of the 2018 diabetes regulation or be disqualified. This means that the driver with insulin-treated diabetes must present for the DOT exam with Form 5870 properly completed. If the driver with insulin-treated diabetes presents for a DOT exam without Form 5870 completed, he must be disqualified. You cannot use determination pending to allow the driver time to get the form completed by the treating clinician. This is analogous to the situation discussed in Module 3, when a driver with monocular vision does not present for the DOT exam with the vision evaluation report form completed. You cannot use determination pending. The medical examiner must retain Form 5870 as part of the medical evaluation report form. The medical examiner determines whether the driver meets the physical qualification standards in order to operate a commercial motor vehicle. In making this determination, the medical examiner must consider the information on the ITDM assessment form, utilizing his or her independent medical judgment. The driver is not physically qualified to operate a commercial motor vehicle if he or she is not maintaining a stable insulin regimen and not properly controlling his or her diabetes. The driver with insulin-treated diabetes may be certified for up to a maximum of 12 months, meaning an annual or more frequent exam by a certified medical examiner. Drivers with insulin-treated diabetes must provide to the treating clinician at least the preceding 3 months of electronic blood glucose self-monitoring records while being treated with insulin to be eligible for the maximum 12-month certification. Insulin-treated diabetic drivers must maintain blood glucose records measured with an electronic glucometer that stores all readings, that records the date and time of readings, and from which data can be electronically downloaded. A printout of the electronic blood glucose records or the glucometer must be provided to the treating clinician at the time of any of the evaluations required by the regulation. If a driver does not provide the 3 months of records, the medical examiner has discretion to grant the driver up to, but not more than, a 3-month certification to allow time for the individual to collect the necessary records. Once the driver has 3 months of blood glucose self-monitoring records, the driver is treated the same as an insulin-treated diabetic driver with 3 months of records and can be certified up to 1 year. The FMCSA did not establish a specific frequency of blood glucose monitoring for insulin-treated diabetic drivers. They must self-monitor blood glucose in accordance with the specific treatment plan prescribed by the treating clinician. Following a severe hypoglycemic episode, the driver with insulin-treated diabetes is prohibited from operating a commercial motor vehicle. The driver must report the episode and be evaluated by the treating clinician as soon as is, quote, reasonably practicable. The driver is prohibited from driving until the treating clinician determines that the cause of the severe hypoglycemic episode has been addressed and the driver again has a stable insulin regimen with proper control of his or her diabetes. The treating clinician then completes a new ITDM assessment form 5870. There is no mandated waiting period following a severe hypoglycemic episode before the driver can return to commercial driving. A disqualifying severe hypoglycemic episode is one that results in a seizure, loss of consciousness or coma, need of assistance from another person. An insulin-treated diabetic driver should not be disqualified for a single blood glucose reading that falls below or above a specific limit. The intent of the evaluation is for an individualized assessment. Per regulation, the insulin-treated diabetic driver is not physically qualified on a permanent basis to operate a commercial motor vehicle if he or she has either severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. So, to review, the pathway for certification of the driver with insulin-treated diabetes is as follows. The driver meets with the treating clinician within 45 days prior to the DOT exam. The driver provides 90 days of electronic blood glucose monitoring to the treating clinician. The treating clinician completes Form 5870. The medical examiner reviews the information from the treating clinician. The examiner performs the DOT exam and issues a medical examiner certificate for up to 12 months if the driver is qualified. Certification of the driver with non-insulin treated diabetes. As mentioned, the 2018 diabetes regulation applies only to drivers with insulin-treated diabetes. Certification of the driver with non-insulin-treated diabetes is based upon FMCSA guidance. The regulatory requirements discussed for insulin-treated diabetes do not apply to non-insulin-treated diabetic drivers. Therefore, according to the FMCSA, a medical examiner may certify an individual with non-insulin-treated diabetes for up to 2 years if the non-insulin-treated diabetes is well controlled. However, it would be fair to say that most examiners will certify a driver with non-insulin-treated diabetes for a maximum of 1 year. Although the regulatory requirement that a driver with diabetes is prohibited to drive following a severe hypoglycemic episode applies to the insulin-treated diabetic driver, guidance recommends also disqualifying a driver with non-insulin-treated diabetes following a severe hypoglycemic episode until the episode has been addressed and the diabetes treatment regimen stabilized. In 2024, the FMCSA released the Non-Insulin Treated Diabetes Mellitus Assessment Form, MCSA 5872. This is an optional tool that the examiner may use to request additional information regarding the diagnosis, monitoring, and stability of non-insulin treated diabetes mellitus in order to assist in determining if a driver meets the physical qualification standards. Again, use of this form is optional. There will not be questions on this form on the NRCME exam. Diabetic retinopathy is caused by microaneurysms and intraretinal hemorrhages in the blood vessels of the retina. As noted, an individual with insulin-treated diabetes is not physically qualified on a permanent basis to operate a commercial motor vehicle if the driver has either severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. Individuals with diabetes whose diabetic retinopathy has reached the advanced stages of severe non-proliferative or proliferative diabetic retinopathy are at risk of sudden loss of vision from a detached retina or bleeding. Treatment for advanced diabetic retinopathy impacts night and peripheral vision adversely, which are important for operating a commercial motor vehicle. With respect to the disqualification determination process, the Insulin-Treated Diabetes Mellitus Assessment Form 5870 asks the treating clinician whether the individual with insulin-treated diabetes has been diagnosed with severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. If it is noted on the form that the individual with insulin-treated diabetes has been diagnosed as such, the examiner may rely on that representation and disqualify the individual permanently from medical certification. Alternatively, the examiner may exercise the examiner's independent medical judgment and request that the driver have further evaluation prior to making a certification decision. Given the impact of non-proliferative diabetic retinopathy and proliferative diabetic retinopathy on commercial motor vehicle driving, the examiner should not certify a driver with non-insulin treated diabetes with either of these diagnoses. The FMCSA does not mandate a regular vision examination nor specify the frequency for comprehensive eye examinations for diabetic drivers. The FMCSA believes that the treating clinician is in the best position to determine for each diabetic driver when a comprehensive eye examination is necessary and, when warranted, to make a referral to an ophthalmologist or optometrist. Per FMCSA guidance, do not certify if the driver with either insulin-treated diabetes or non-insulin-treated diabetes has orthostatic hypotension, has a diagnosis of peripheral neuropathy, has loss of position sensation, has loss of pedal sensation. Hemoglobin A1C. The FMCSA does not define a specific hemoglobin A1C level which mandates disqualification. Although the FMCSA has stated in the past that a hemoglobin A1C greater than 10% is an indicator of poor blood glucose control, it emphasizes in the 2018 diabetic regulation that hemoglobin A1C levels are but one factor the treating clinician may consider in making that determination. Hemoglobin A1C values should not be relied upon as a sole measure of an ITDM individual's ability to safely operate a commercial motor vehicle. Making a medical qualification determination based solely on a specific hemoglobin A1C level is inconsistent with the rule's emphasis on individualized assessment. In addition, the National Institute of Diabetes and Digestive and Kidney Disease states that hemoglobin A1C test results can be up to 0.5% higher or lower than reported. They can be unreliable for people of African, Mediterranean, or Southeast Asian heritage, and can be altered by diseases that affect blood or hemoglobin. While a high hemoglobin A1C level may suggest that complications from diabetes might develop in the future, it does not mean that an individual presently has complications or is unsafe to drive a commercial motor vehicle. The Insulin-Treated Diabetes Assessment Form 5870 asks whether the driver has had a hemoglobin A1C measured intermittently over the last 12 months, with the most recent measure within the preceding 3 months, and if so, to attach the most recent result. The FMCSA notes that the lack of a hemoglobin A1C result does not automatically disqualify a driver from being medically certified. A dipstick urinalysis is a requirement of the commercial motor vehicle examination. When the blood glucose exceeds a certain level in the blood, the kidneys secrete excess glucose into the urine. The blood glucose level as to when this occurs varies by individual and is impacted by kidney function and various medications. Glycosuria can occur at low or even normal blood glucose levels. The examiner should consider obtaining a fingerstick glucose because often the blood glucose and urine glucose do not correlate. Glycosuria may detect drivers with undiagnosed diabetes and identify drivers with poorly controlled diabetes. Proteinuria may reflect glomerular damage from diabetes. The examiner determines certification of the driver with an elevated glucose or proteinuria. The examiner may elect to issue a short-term certification to allow time for the commercial motor vehicle driver to follow up for further assessment. This concludes Module 9.